Hello, my name is Janet and I'm a publisher with Elsevier. Medicine Journal is a collection of current reviews for internal medicine training exam revision, as well as for continuing professional development. Medicine's editorial board comprises of subject matter experts across all subspecialties of clinical internal medicine. As we publish each chapter in the journal, our chairman, Albert Ferro, will be interviewing the relevant board member and chatting to them about their specialty. We hope you enjoy them. To find out more about Medicine Journal, including how to subscribe, please visit www.medicinejournal.co.uk. You can also follow us on Twitter using the handle @MedicineUK1.
Hello, and welcome to the latest videocast for Medicine Journal. My name is Albert Ferro. I'm a professor of clinical pharmacology, and I'm the chair of the editorial board of Medicine. I'm delighted to have with me Dr Faisal Hasan. So welcome, Faisal.
It's nice to be here. Thank you, Albert.
And Faisal is joining me because he is the chapter editor for the latest two issues of Medicine, which are the September and October 2025 issues, which are all about endocrinology. So we'll talk a bit about endocrinology, things that we think are important for general physicians to know. But before we do that, maybe Faisal, could you tell us a bit about yourself?
So, hi, Albert. It's very nice to edit the journals in September and October, and we covered a lot of endocrinology. I used to work as a consultant in Southmead Hospital in Bristol. I recently moved to Calgary in Canada, so I'm working as an endocrinologist here.
Good, excellent. So you've changed to very different climes then.
Yes. Well, it's still automating in both places.
So you're the chapter editor for these issues, and just to say, we'll touch on some of the issues there. We might sort of stray a little bit and talk about other issues which we think are interesting and of relevance to general physicians. But just to say to viewers that if they want any more detail on any of the things we're going to talk about, or indeed any other aspect of endocrinology that we don't talk about, please do go to the September and October issues of 2025, where you'll find lots of detail there. So perhaps we'll start with a little discussion about endocrine hypertension. Now, I, as a clinical pharmacologist, treat hypertension. That's one of the things I do. But endocrine hypertension is quite a specialist area, isn't it? And it's probably quite important for people to know about. Perhaps, Faisal, would you like to say a few words about it? How common is it? Should people be thinking about it when they see hypertensive patients?
I think that's a very good topic to begin with. So we've had a big paradigm shift in hypertension per se. And we used to think that causes of secondary hypertension are quite rare. And just recently, the Endocrine Society has published guidance on primary aldosteronism. And I think the readers will be surprised to know that they have completely changed the screening criteria for whom we should consider screening for secondary hypertension or endocrine hypertension. And they said the incidence of primary aldosteronism is much higher than we used to think previously. And they said now all patients should be screened for primary aldosteronism. Now, this is slightly different than what we cover in our article because the guidelines came after that. But the guidelines, the article has some important points on when to suspect primary aldosteronism more. And there's a very nice table in that article which highlights patients who, for example, are not controlled on 3 hypertensive agents, the patients who have had either spontaneous hypokalemia or diuretic-induced hypokalemia, or patients who are younger in age. So there has been a shift about trying to identify patients with endocrine hypertension. And because primary aldosteronism is more common than we used to think, so I think it'll be important for everybody who treats hypertension to think about this and screen about this.
I'll just say a few words from my personal experience. Now, the hypertension clinic we run is predominantly for patients with resistant hypertension, and also patients with young onset hypertension. And the NICE guidelines here say that if you've got a patient who's under 40, they should be referred for further investigation. So I would say that pretty much all of the patients that come through our clinic do get screened for primary aldosteronism. Are you saying though that this should be a screening that's done in all patients, even in primary care as well?
So I think the guidelines do recognize that in up to 30% of the patients who've been referred to a hypertension clinic, they've diagnosed people with primary aldosteronism, and up to 14% of hypertensive patients have primary aldosteronism. So obviously this depends on the setting, the resource availability, but what the guidelines and what the article highlights is actually screening can be done in primary care. And it's all about sending a renin aldosterone ratio, which needs to go to the lab. And even it can be done on the patient's medication that they're currently on. So the guidelines are moving away from trying to change the medication, because sometimes it's not practical. You have patients who have difficult to control hypertension. It's very difficult to switch the hypertensive medications to the ones which do not affect the renin aldosterone ratio. So the guidelines are recognizing this fact, and they've asked, like, try and send a screening test. Now, in my experience in England, the sample would be stable for about 4 hours till it reaches the lab. So I think that's important to understand, that your sample should reach the lab. But yes, they do kind of suggest now trying, because the reason is if 14% of the patients who have hypertension can be treated with more personalized medicine, that can have better cardiovascular outcomes. And the reason I say that is when you look at the data, primary aldosteronism patients compared to patients with essential hypertension have increased risk of atrial fibrillation, increased risk of stroke, and increased cardiovascular morbidity. And this comes because something is happening due to the high aldosteronism. And that's why they're trying to focus on, we can actually make it more personalized and try and reduce these extra risks. So I think having a simple screening test, which is a simple blood test, is still quite doable.
Indeed, yes. It's something that I think we need to catch up with in the UK, because at the moment, I think that as a screening tool, aldosterone to renin ratio is not available in primary care. And they get referred to us because we're the people who have to do it. So I think there's a bit of catching up that we need to do. But you're absolutely right, I think, that if 14% of hypertensive patients have primary aldosteronism, that needs to be identified and treated specifically.
I was going to say about is that when you do the renin aldosterone levels, often you get a ratio.
Yep.
So, and people often look at the ratio and then decide, okay, based on the cutoff it's given in the report, okay, above 60, above 30, depending on the units you use, is this suspicious or not? I would ask the readers to look at the renin itself and the aldosterone itself. And what we are trying to look for is a suppressed renin with an inappropriately high aldosterone. I think you need to look at that before you look at the ratio itself, because that gives you a little bit more information. And now there is more recognition that the disease is a continuum. They're trying to move away from very fixed cutoffs, and they think that there's an entity called subclinical primary aldosteronism. There's lots of data on that. So I think just looking at the ratio and then dismissing that this is not PA is something we should move away from. The guidelines give quite, and even the article has nice cutoffs on what to use as renin markers, the different units, direct renin ratio, concentration, plasma renin activity, and what is an inappropriately high aldosterone for that particular renin.
You make a very important point about inappropriately suppressed renin, I think. And one of the things I would add to that is that if the renin is still suppressed despite being on good doses of ACE inhibitors and diuretics, then that is a real indicator of underlying primary aldosteronism, or that the patient's not taking their tablets, of course, which is the other possibility.
Yes, absolutely.
Yeah. So that's the important one there, primary aldosteronism. And the other one that occurs is pheochromocytoma, which I think is probably rather rarer than that. But what's your experience of pheochromocytoma?
The natural history of pheochromocytoma has changed. So now how we detect pheochromocytoma most commonly, somebody who was found to have an adrenal adenoma on CT scanning for some other reason. And because they were hypertensive, we checked their plasma or urine metanephrine, and then they found that this was elevated. So I think having somebody presenting with the classical findings of episodic flushing, sweating, headaches, hypertension, that has become less common. And often now we are diagnosing it as part of workup of a hypertensive patient with an adrenal adenoma. It still remains very rare. And again, there are caveats to testing. Some drugs interfere with that. So it is still, so for somebody who has an adrenal adenoma and who has Hounsfield units more than 10 on that, then you would, and is hypertensive, then you would suggest that these people be screened for pheochromocytoma.
Okay, good. Thank you. Let's go to another topic now, and I think one that's of very great relevance to the general physician is how to interpret thyroid function tests. And I think that's maybe something I'll ask you to elaborate on when you've got your set of TFTs in front of you, how to interpret what they mean.
I think this is a very important question because it's a very common clinical problem encountered by family physicians and internal medicine people. So there are three articles which I would like to highlight in this journal. One is about interpretation of laboratory tests, which is an introductory article, and talks about immunoassays and what kind of problems we can have with immunoassays. Now, people need to remember that the endocrine tests are not black and white. Sometimes you can get results which are not internally concordant. For example, if you have somebody with hypothyroidism and you check their TSH, you would expect that to be elevated and the T4 should be low. We don't check the T4 all the time, but let's say somebody did check a T4. And then you get a T4 which is normal and the TSH which is elevated. Then you are stuck because it's slightly not internally concordant. And then you're trying to think, okay, why is the TSH elevated and the T4 is normal? I can say this is subclinical hypothyroidism, and the article in the journal covers, okay, what is subclinical hypothyroidism? What kind of patients should we, what kind of patients do we see it? What is the etiology of this and how do we treat this? So I think in the interpretation of the thyroid function test is subject to immunoassay interference. So I think the article on that will really help people go through the nuances in laboratory interpretation of endocrine tests. Then we have a couple of very nice articles on hypothyroidism and hyperthyroidism, both a common clinical problems. So hypothyroidism is what I think people will see more oftenly. So there is a nice review article on that which covers levothyroxine, what kind of dose should we give, what's the ideal what's the median requirement of levothyroxine for a person's body weight. And then hyperthyroidism, I think it's important for people to understand. Now, you've got somebody who's really thyrotoxic, they've got tremors, a high heart rate, a lot of autonomic symptoms, and you want to refer them to endocrinology, but you do want to start something before that. So in that case, starting them on a beta blocker, starting them some carbimazole to begin with, and making sure that we request basic investigations like the TSH receptor antibodies, which helps us identify what is the underlying etiology of this hyperthyroidism. I think those are very helpful tips in the article, which is covered. And then also what happens is the patient can feel much better while they wait to see a thyroid specialist.
And what about, are there any other tests that should be done pending referral to an endocrinologist? So is there any place for doing thyroid imaging, or should that be the sort of thing that's just left to endocrinologists to investigate further?
So I think a routine thyroid ultrasound would not be indicated in both hypothyroidism or hyperthyroidism. There are very nice guidelines by the NICE, NICE in England about when to do thyroid imaging in somebody suspecting thyroid nodules. Imaging-wise, let's say we see somebody who has hyperthyroidism, and we do the TSH receptor antibodies, and these are negative. And then you've done a thyroid ultrasound at that time to see if you can see any nodules, because now you're thinking, is this a toxic multinodular goiter or a solitary toxic nodule? And then the best imaging in that situation is to do a technetium iodine uptake scan, and that will give you the etiology of the hyperthyroidism. But I think that is often left for specialists to do.
That's very helpful. Let's turn to Addison's disease, which is another important thing that general physicians need to know about. And perhaps just run through when to suspect a patient might have Addison's.
So presentation of Addison's can be quite subtle and often takes sometimes years to diagnose, because they can have tiredness, they can have vague abdominal symptoms, they can have mild hypotension. So often it's not unless they present with an adrenal crisis, it's not clear, so not glaring at you that this patient is Addison's. But I would say anybody who has unexplained hypotension, anybody who has other autoimmune conditions and is complaining of fatigue, and every other investigation you've done is normal, then screening them with the morning cortisol is quite helpful. Now remember, to diagnose Addison's, the morning cortisol is just a screening test. So, and everybody has a different cutoff. So it depends. So it's important to know your laboratory's 9 a.m. cortisol cutoff. And let's say it is less than that, then you would do a ACTH stimulation test or a synactin test, in which you give the patient ACTH. And then what you're trying to do is measuring a stimulated cortisol and seeing if that's normal or not. So if the patient does not have a normal response to ACTH, then you suspect this patient has Addison's disease. Now, Addison's disease, often we would like to do an ACTH as well to differentiate it from secondary adrenal insufficiency, which is a problem in the pituitary gland where you're not producing enough ACTH. Whereas Addison's disease itself is an autoimmune condition of the adrenal gland themselves. And the article and the issues does highlight the difference between these two conditions, because in Addison's disease, which is the autoimmune condition which affects the adrenal glands, you also have lack of mineralocorticoid secretion. So these patients will need fludrocortisone. Whereas if you have somebody who has a pituitary tumor and because of that they have low ACTH causing adrenal insufficiency, those people will not need fludrocortisone. Other reason to think about this is often we use immunotherapy for cancer, multiple myeloma, lung cancer. And there are 2 articles on this which talk about this. We've seen more adrenalitis and hypophysitis with immunotherapy than we had seen before any other drug. So I think this is another scenario where you suspect Addison's disease, that somebody's had immunotherapy and now they're complaining of tiredness. And then you should screen with a low AM cortisol, we should screen with 9 AM cortisol. So that's important to remember. That's something new and different. And that's also can cause both adrenalitis and hypophysitis. So that's something I would think about when somebody is talking about Addison's disease.
And can I ask you, how useful is it to look at the electrolytes? You know, a common MRCP UK question, of course, is, you know, you've got a patient with hyponatremia, hyperkalemia, low glucose, you know, the classic things of Addison's. Is that actually common, or is it equally common not to have any of those things?
I think I would say if you have somebody with unexplained hyponatremia and you've done all the investigations, morning cortisol should be part of your screening, because you don't want to miss Addison's, because it's something which can be treatable. So I think some patients can present with hyponatremia, some patients can present. Hypotassium, I think, is slightly rarer, but I've also seen isolated hypercalcemia sometimes, and you don't find a reason for that. And that can be seen in Addison's disease. So I think looking at the electrolytes does give you hints. So if you have a sodium which is low and then the patient is tired, then you should think of doing a clinical examination, looking for hyperpigmentation in the skin and the mucosal membranes, and then do a morning cortisol for that patient.
And you mentioned earlier on adrenal crisis, and that's obviously something that general physicians need to be very aware of, isn't it?
I think you're right. I think that's something very important because it is preventable. So there are guidelines on what to do with stress dosing. Now, remember that when we have a fully functioning hypothalamo-pituitary adrenal axis, when we are stressed, like example in surgery, in infection, then our cortisol output is increased. Now, patients with Addison's are unable to do that. So when they are undergoing a procedure, when they are undergoing a dental procedure, for example, this can be in an outpatient setting, or somebody is having an endoscopy, or somebody is having a minor surgical procedure. There are very good guidelines on how to prevent this, how to double the dose of steroids. Also, very important that we have had a big initiative on trying to identify people who have Addison's and treat them early. So we encourage all our patients to get a medical alert bracelet or a card, and then the MHRA and the Endocrine Society has issued a red colored steroid card. On the back of that, it says what is the emergency treatment of adrenal crisis, because again, this is something which is life-threatening, but again, early treatment can make that much more, less complicated. So I think it's important that people are aware that these patients, actually what I would suggest is for hospitals, we had a system for alert. So as soon as the patient with Addison's is to come into the hospital, as soon as you open the electronic medical record, there should be an alert that this patient has Addison's disease. Then you immediately know, okay, I need to double the dose of the steroids for this patient.
And perhaps to finish with, we might just sort of touch on another endocrine. It's not an abnormality as such, it's not a disease. It affects half the population, of course, and that's the menopause. And of course, some women who experience premature menopause as well. So perhaps I could just ask you about investigating women who present with the typical menopausal symptoms, and in particular, perhaps people who are presenting it with it at a young age, how to investigate them.
I think that's a very good topic to talk about, because it's something which can be missed. So often patients will delay seeking medical attention when they've not had a when they've had amenorrhea for a couple of months, sometimes people wait for 6 months to see if it's going to come back, and they don't seek medical attention. And sometimes when they seek medical attention, we need to think about premature ovarian insufficiency, POI. So the test we often do is an FSH level, which is a follicle stimulating hormone level. And that tells us whether this is going to be elevated, which can be seen in premature ovarian insufficiency and menopause. We often do it on 2 occasions, just to make sure patients will have symptoms of estrogen deficiency. And the other important thing is we know that a lack of estrogen is not good for bone health. So this can result in osteoporosis down the line. So identifying it and then treating it appropriately is not only helpful for the patient's symptoms, but also it's important to kind of prevent osteoporosis and make sure the patients are getting adequate treatment for that. So there has been again a shift in this area about menopause, and there had been a lot of concerns about breast cancer and other side effects from the hormone replacement treatment. And there has been a shift in that. So people recognize that perhaps the risk is not as high as we used to think in the past. And the article again kind of goes through special populations as well in the Addison. So they talk about patients who had breast cancer, patients who had other problems which can, like thromboembolism, and how do we treat these patients who we want to give hormone replacement treatment because they are symptomatic, and what do we do in these situations? So I think sometimes it can become quite nuanced, and then you need a menopause specialist. But I think for patients who have symptoms without any significant risk factors, how to kind of think about starting treatment, what kind of investigations to order, are all there in that article, which is quite well written. So people can have a look at that.
And are there any newer treatment options that are available?
Yes, so there is a drug called fezolitant. So I often get the pronunciation wrong, but basically how that works is it works on the kisspeptin neurons and helps with climacteric symptoms. It's a completely new class of drug, and that's very exciting. And there are other things as well which are covered in the article about non-pharmacological treatments of non-hormone replacement treatments of menopause. So there's some class of drugs as well, lafaxin, etc., which are mentioned there, which you can have a look about and think about when you cannot, let's say there's an absolute contraindication of giving estrogen in that situation. And you can think about what else can I do to help my patient.
Faisal, it's been a great conversation. Some interesting things to refer our viewers to. So thank you very much for joining me today.
It was very nice talking to you, Albert, and I hope people will find the articles good in the 2 issues we have done.
Thank you. Thank you.